Good afternoon. Thank you for coming to this event. We are so pleased to have Professor Gerald Friedman coming all the way from UMass Amherst to give us this talk, and he will have another talk tonight at the First Presbyterian. Later on, we'll make that announcement.
Dr. Chi, just before Dr. Chi introduces Professor Friedman, I'd just like to invite all of you, 7 o'clock tonight at Dennis Hall. It's the 9th and Monroe, part of the Presbyterian Church. You're all invited to come and hear his presentation tonight, and then afterwards there'll be a reception where you can come and meet Dr. Friedman. The main event is free to the public, open, and $15 for a ticket. I think we may have some tickets here today available. If not, you can buy them there to meet Dr. Friedman at the reception. That'll be at 8:15. Thanks very much, Dr. Chi.
Thank you. And this news talk is co-sponsored by many organizations, including Healthcare for All Oregon, Main Street Alliance of Oregon, Mid-Valley Healthcare Advocates, Physician for National Health Program, Oregon Chapter, OSU's College of Public Health and Human Science, and this is the first sponsored event by the newly established Center for Global Health at Oregon State University. Let me briefly introduce Dr. Friedman. Dr. Friedman is currently a professor of economics at UMass, University of Massachusetts, Amherst. He completed his degree, bachelor degree in economics and history from Columbia University, and then PhD in economics from Harvard University. And his professional experience, there's a long list. I'm just going to highlight a few. He has been working with the International Ladies Garment Workers Union, with the Department of Economics in Tufts University, and also with Clark University. His research interests span from economic history, the world slavery, labor history in both Europe and North America, labor economics, and most relevant to his talk is health economics. He received numerous honors and awards, and with a long list of publications, I will not bore you with that long list. He's also very instrumental in working with Vermont, state of Vermont, which was and has become the first state in the union to officially pass a Universal Health Care Act. So he was very instrumental in providing the necessary research. Not only that, he continued to do research related to the federal level, the HR 676 research that I was also involved in that part. And before we start, I had a brief chat with him, and we have another indirect connection. He's a close acquaintance with my thesis advisor at Harvard, Dr. Bill Xiao. So he also worked with Bill Xiao. So let's welcome Dr. Gerald Friedman.
Well, thank you very much. You're all very kind, and I want to thank Oregon State for having me, and of course my hosts who have been driving me around and putting up with my snoring in the car. Along with all the stories about my dog and whatever. If you want, we'll talk about the dog later. He's much more interesting than me, actually. But anyway, we're going to talk here about a concept that I kind of began my professional life with. As was said, I write about history, labor history, United States and Europe. My first book was a comparative study of the origins of the labor movement in the United States and France. A topic actually quite relevant to the Pacific Northwest, because I was interested in why syndicalism, revolutionary syndicalism, as in the IWW, failed in America, but became the predominant ideology of the French labor movement before World War I. So many of the towns that we've been driving through, I remember from my days studying the Wobblies. And that's kind of exciting, even if they've changed maybe a little bit since 1906. But anyway, we're going to be talking about a different version of American exceptionalism. How American healthcare not the way we finance and administer healthcare is not only different in the United States, but we've also, for the last 40 years, been going in a different direction than in other countries. When I say other countries, I basically mean all other countries. We have a very different healthcare system, healthcare finance system, and it's been becoming more different. So we're going to talk about that, how our healthcare financing system is different. We're going to talk about how the outcomes of healthcare differ in the United States and other countries. It's almost as if we've been conducting a social experiment. What happens if you set up a healthcare system organized around the idea that what physicians do is a consumer activity comparable to people going bowling? So when I go to the doctor, it's like I'm buying a consumer service with no particular social value. When I was in graduate school, back in Paleolithic times, Richard Zeckhauser of the Kennedy School, who had been a health advisor to Presidents Nixon, Carter, and later Clinton, Zeckhauser came to a seminar, sat down, and told us how doctors have done nothing to extend life expectancy. Going to the doctor is of no particular value. It's something people do because they like to go to the doctor. They enjoy having that attention, and that's fine. If people want to spend their money on some service, go ahead and do it, but don't abuse it. Abusing it means you're getting more than what you're paying for, so somebody else has to be subsidizing it. And that's what goes on in healthcare, he says. We subsidize people's healthcare consumption through the insurance system and through government programs where people are not paying for healthcare on the margin. You get it for free. So of course you use too much, and that's the root of our problems in healthcare. And the solution to our problems in healthcare, rising healthcare costs, rising share of gross domestic product going to healthcare, the solution then is obvious. Raise the price. Charge people for their use of healthcare. We call that cost sharing. And it comes in the form of co-pays, deductibles, and the like. And that's what we've been doing. We've been trying to control rising healthcare costs by piling in more consumer cost sharing. Treating healthcare as a commodity. This is different than is being done in the rest of the world, and with different outcomes. We're going to talk about what we'd expect from economic theory, and we're going to talk about how we could have a better system, HR 676. How our healthcare system differs. Well, first, it's largely private. It's not mostly private. About half of healthcare spending in this country is public. About half is private. Largely through employer-provided health care. Employer-provided, but not necessarily employer-paid for. Because there's growing share of health insurance that you get through your employment that workers pay for themselves. There's something interesting about the largely private, because as we'll talk about, healthcare in the United States is roughly twice as expensive as healthcare in other countries in the Organization of Economic Cooperation and Development. You may have caught before I said how close to half of healthcare spending is public. If we got rid of all private expenditure and administered healthcare as efficiently as is done in the rest of the world, the public money we are already spending would be enough for all the health care that we get. That's kind of an interesting thought. Okay, we treat health care as a privilege, not a right. You don't necessarily get it. If you don't have the money to pay for it, you don't get it. And notwithstanding what Professor Zeckhauser said, if you don't get the health care, you die. Sometimes, not always. There's universal coverage in every place else, in contrast with the United States, U.S., many without, other countries in the OECD, the affluent OECD, everybody has health care coverage. Two aspects of that. Not only do people have insurance, but they have access. Technically, you can have access without insurance if you're rich enough. You can also have insurance without access. You can have insurance that doesn't really give you access because of high co-pays, high deductibles. You have a $5,000 deductible. Your access to primary care is limited to your ability to pay for it. Okay, all of the OECD, Organization of Economic Cooperation and Development, have universal coverage, except Mexico and Turkey, countries that don't belong in the OECD anyway, because they're too poor. We spend more than everybody else. Here's healthcare spending as share of gross domestic product. I mean, you look at this, and the concept of American exceptionalism has been long debated in labor history and economics. Are we really exceptional, or are we just like everybody else except bigger? This, that, whatever. But no, here there's no question. Look at this line. Here's everybody else. These are the countries in the Organization of Economic Cooperation and Development. When I was in grad school, we called this the Club of the Rich, because it was an extra credit if you know where the OECD came from, its history. But I'm not going to tell you that. You have to figure it out for yourself. Anyway, the Club of the Rich. But in the 1990s, for political reasons, the Clinton administration and the EU, Europeans, started pushing to let in riffraff countries that don't belong. So, if you take the data from the OECD, which is a great data set, it's OECD.org, their statistics are wonderful. They even tell you which ones are most useful, because they have a file, frequently requested healthcare statistics. And it's an amazing data set with all these different countries, lots of different things, diabetes, doctor visits, MRIs, it's wonderful. Anyway, if you just use the data as I did here, you'll see that you've got all these countries at the tail end. These are poor countries, or relatively poor countries, so they spend less on healthcare. But if you go over here, you're dealing with countries like Canada over here, Denmark, Austria, Belgium, the United Kingdom, Germany, France. These are countries we're comparable to. Comparable per capita income. Comparable in many dimensions, except they spend about half what we spend as a share of gross domestic product. You don't have to compare us to Mexico and say, oh, well, we spend 4 times as much. Compared to France, we spend twice as much. This is what I was saying about our public spending. This is a share of gross domestic product in the United States. We're losing some of it. Gross domestic product in the United States, public spending only. Our public sector spends close to 9% of gross domestic product on healthcare. That's alone more than Canada spends on healthcare. Total, public and private. Now, to be sure, in every other country, most spending is public. So if you compare this with the previous slide, the numbers for other countries are very similar because most spending is public. The United States is a big difference. We've gone from up here to down there. This is the average for the OECD, but it includes all these countries, so it's not really very useful. Here's dollars, because not only do we spend a higher share of GDP, but technically we are richer than virtually all the other countries. Luxembourg is richer, but Luxembourg is this tiny little thing that's basically just a rich city. It shouldn't really be a separate country. There are all sorts of places that shouldn't be a separate country. Or shouldn't be in the country. I'm from Massachusetts and New York, so as far as I'm concerned, there's this big blot of land between us and you. It's like, why? Okay, anyway, here's the United States. We spend close to $9,000 per person on healthcare. That's a lot of money. Here's France. They spend less than half as much, $4,000, and they get August off. Is that? And they get to live in Paris and the South? I mean, is that fair? It's like we have to spend all this extra money, and many of us have to live in Texas. And we're not getting our money's worth. This is, we're going to have a couple slides on this. This is kind of a bottom line issue in comparative U.S. versus the rest of the world. We are not getting our money's worth for what we're spending, and there are many ways to look at it. We do have a decent life expectancy. Americans have a pretty good life, and it's pretty long. But it's not as good as other countries, and it's certainly not as good given all the money we're spending. When I started out in the world, my advisors were working on height by age. And Americans used to be a lot taller than everybody else, which was taken as a measure of standard of living. If you go back to the revolutionary times, Americans fighting in the Continental Army were not only morally superior to their British and Hessian counterparts, but were about 3 inches taller because we ate better and we had healthier lifestyles. We didn't get, all the stuff that in the British water, we had relatively clean water. We were outdoors. We were great. And we continue to be taller than everybody else. This is remarked upon by people in Britain and in Germany when the U.S. occupation armies were there after World War II. American soldiers were taller. They talk about, the GIs are so tall. Well, by the 1970s and 80s, the Germans, the Dutch, the Danes, the Scandinavians had caught up to us in height. The French had caught up to us. They kept going. And now, Americans are like an inch shorter. The adult Americans, born in the 1970s, are an inch shorter than people born in the 1970s in Germany, Denmark, Scandinavia. Even the Brits are getting taller than us. And that's reflective of the general life expectancy of Americans. It hasn't gone down very much except for poor women, which we'll get to. But Americans have lost the advantage that we used to have. We're continuing to spend the money, but we're not getting the benefits. Even insured Americans, even Americans with health insurance, have shorter life expectancy and a higher morbidity rate than do people in other countries, other advanced capitalist countries. We have more cost-related access problems, and this gets at one of the key things about why our life expectancy is shorter, which I already gave a clue about when I mentioned poor women. The disparity between life expectancy for poor Americans and rich Americans is much greater than the disparity for people in other countries. And that reflects cost-related access problems. Way more Americans and way more people in poor counties in Oregon report cost-related access problems. They did not fill prescriptions. They did not go to the doctor because of cost. That's way more common in the United States and especially for poor Americans and working Americans, than in other countries. And Americans think the healthcare system's worse. They're right. Okay, here's life expectancy. Again, I've included all the OECD, including the riffraff. Americans do not live as long as people in Estonia. Oh my God, Estonia is next to a country that my wife's relatives are so lucky that they got out of. Here's Poland, which goes unspeakable, where I grew up. Turkey, Mexico, okay, we're rich, we live longer than them. But compare us to countries comparable. Germany. These are women, female life expectancy. Same for men, but women are better, so I use them. Belgium, Germany. The Germans, I thought they lost the wars. They live like 2 years longer than us. Canadians, do they really have a right to be a separate country? 2.5 years longer than us. Well, forget Luxembourg. I already said about that. But over here we have France, covered up by this thing. But they live 5 years longer than us. And the Japanese, again, They lost the war, but they eat sushi, and they go to the doctor. Oh boy, do they go to the doctor. Way more than we do. 3 times as often as we do. And they live to be almost 86. While we barely make it to 81. When I say we, I mean the women here. No. Men are less. Okay, this is, the data source insisted on lumping men and women together, which, as long as the ratios are the same, it's not terrible, but I really wish people wouldn't do that. Because, it's sloppy, since men and women have distinctively different life expectancies. It's not totally clear why. My wife has an explanation. Do you want to hear it? Yeah. Men have defective genes. Everyone is supposed to be female. But, you start out female, she says, and then something's done to you, and it's bad. I have 2 daughters, so I guess I have to agree. She did let me have a male dog. But that just kind of made her point. Okay, anyway, here's everybody. Everybody, Americans, shorter life expectancy. Americans with health insurance. Now, these data, I calculated these separate on my own. These are from the Commonwealth Fund and the national statistics. These I did on my own. Actually, I could have gotten these from the OECD for men and women and not bothered with and done it myself. But remind me to do that next time. But anyway, these I calculated myself based on estimates of different mortality rates for insured and uninsured. Americans without health insurance have a life expectancy of approximately 70 years. If you never had health insurance throughout your life, you'd live to be 70 on average. About. With health insurance, Americans make it all the way to like 79 and a half. Having health insurance helps. But even Americans with health insurance have a shorter life expectancy than people in every other country. There's one anomalous country here, by the way, and if anybody knows about it, please drop me an email, let me know, because it really bothers me and bothers everybody I talk to about it. Denmark! Why is Denmark life expectancy so short? They're too happy. Yeah. Maybe it's too much schlong, whipped cream. Yeah, maybe, but it doesn't show up in obesity. They do all the right things. They bicycle, they have long vacations, they have national health insurance, they have good primary care. I mean, they do all the things you should do, all the things that Canada, that France does. And they die at a much higher rate. Not as high as the United States, but, closer than anybody else. We don't live as long because our spending on healthcare is inefficient. Here's per capita healthcare spending for OECD member countries. This is female life expectancy at birth. Notice, contrary to what Zeckhauser said, and I love saying this because when he said this, it really bothered me, but there were reasons why I couldn't argue with him. I mean, first, he was much more important than me. That's the main reason. But it didn't stop me with other people. But and second, because in the early 1980s, it wasn't clear that healthcare spending was helping. But there's no question it is now, and we'll talk about that some more. But here's healthcare spending per capita. Here's female life expectancy at birth. Guess what? It's an upward sloping line. Here's the regression. An R squared of 0.37 or 3.6. That's not bad. 3.6. Oh yeah, 3.7. Yeah, that's not bad. Actually, that's a very good R squared for a cross-sectional regression. Over a third of the variation in female life expectancy is explained by this one variable: how much you spend. And more spending on healthcare, longer life expectancy. We buy more life expectancy by spending on healthcare.
Who are those two countries?
Okay.
Those are high leverage.
This is Denmark. You can see why it bothers me.
Yeah.
But here's the U.S.
Yep.
We're not getting the return on our spending.
What's the far upper left?
That one, I believe that's Hong Kong. I'd have to check. Given the regression line, we should have 4 more years of life expectancy. Or we should stop spending $6,700 per capita. If we're going to live only as long as people in Portugal, why do we spend $6,700 more per person? I mean, a family of 4, that's $27,000. I mean, this is real money. Yeah. The younger people in the audience can be thinking, oh boy, there's my college loans paid off. The older people in the audience can be thinking, I could use this 4 more years. Yeah. Now, to be sure, the younger people in the audience might say, I don't care about the 4 more years, because given what's been happening in the last 25 years, I'll get those years anyway. Because life expectancy has been increasing dramatically in the last 25 years in OECD member countries. Now, it's been increasing in Egypt and India and other places, but those are poor countries. They didn't have clean water. So there's been a lot of low-hanging fruit in those countries. Just have clean water, and right away you'll get 30 years of life expectancy. But in Germany and France, let's see. Here's France. That one. Here's Italy, I believe. They've been adding 4 or 5 years of life expectancy in the last 20 years. And these are countries that already had good life expectancy. Why? Well, look at what doctors have been doing in the last 20, 25 years. Better treatments for cancer. Cancer survival rates have been going up. Better treatments for blood pressure. Better treatments for all ranges of ailments. There have been improvements in medical technology, and they've shown up. I mean, you could say there are other things, nutrition, whatever. The only other thing that's really improved dramatically in the last 30 years is smoking rates have declined. Obesity has gone up. I don't think you could make a serious argument that nutrition has improved significantly in the advanced capitalist world since the 1980s. Obesity's up. Are people, given that everything else, are they eating better food, more fruit and vegetables, more vitamin C? I don't think so. I don't think there's any really good evidence there. They're not smoking as much, and that's contributing to this rise. But not very much, because smoking declines that have happened in the last 20, 25 years have not had time to translate into lower lung cancer and emphysema death rates. In the United States, we actually get a little bit of a boon because our smoking began declining before other people's. Also, motor vehicle accident death rates are down in the United States compared to the rest of the world. And that goes back to seat belts in the 1960s. Ralph Nader's induced improvements in automobile design in the 1970s, and then airbags in the 80s. All innovations that came first in the United States. Well, not seat belts. Seat belts came first in Sweden, but they came in the United States before, most other countries. So when you take those account, we should have an extra boost in life expectancy. And then medical technologies helping everybody live longer. Well, who's getting the benefit? Here's the United States down here. The smallest gains in life expectancy for women, these are for women, change in female life expectancy. Male is similar. Women are doing better in the United States, but not as much as in other countries. And that's happening even while we're spending way more money. We're putting more extra money. Down here we have the change in per capita healthcare spending. We are an outlier. We're spending way more money, and we're not getting anything near the benefits that other countries get. Here's the cost of getting another year of female life expectancy. Higher in the United States by far than in any other country. Norway is spending more, the Netherlands, but we are almost double what that cost per year. And then you get to countries like France down here, Or Italy, over here, Italy, it costs less than $500 a year to get a year of additional female life expectancy, compared to almost $2,000 in the United States. Later today, if you're nice, I'll tell you my stories about healthcare in Florence, Italy, when my daughter got sick. But we are inefficient, which is the worst thing to be if you're, from the perspective of economists. Yeah. I mean, from the perspective of normal people, it's bad enough that we don't live as long and we die more. From an economist, it's like you're wasting money. That's terrible. Talking about wasting money. Here's healthcare costs as share of GDP in the United States and Canada. Starting when it's very convenient. I told you this is like a social experiment. The Canadians were so nice. They did introduce the national single-payer plan at a year when the United States and Canada had almost equal healthcare spending as share of GDP. So we're starting from the same base. And look what happens. Canada has gone up. There are reasons why you go up, your spending rises. Healthcare is a labor-intensive activity. You kind of expect it to become relatively more expensive over time. Healthcare is an income-elastic activity. It's something you want more of as you get richer. So you expect its share of GDP to rise over time. Healthcare spending depends in part on the age structure of the population. As you live longer, there'll be a drift up in healthcare spending. All that goes on in Canada, it goes on in all the countries of the OECD. And it goes on in the United States. But the United States is way more. I mean, look at that, uniquely U.S. I called it uniquely here. It could have been called exceptional. We are exceptionally inefficient. Here's, again, uniquely U.S. This is the same thing compared the United States with the OECD average. In this case, because the data go back to 1960, I did 1960. And we're not the same in 1970. By the way, who knows the name of the person responsible, whose name is associated with the Canadian single-payer health plan and his grandson? Kiefer Sutherland's granddad, Tommy Douglas. Yes. Extra credit for you guys. Yeah. And there's a movie about the Canadian healthcare system that somebody gave me, a documentary narrated by Kiefer Sutherland. So I haven't opened it yet to watch it, but it's just one of the many really nice things that people have been doing for me on this trip, for which I am very grateful. Rising healthcare burden on budgets. I mean, it's like, okay, you're spending more and more on healthcare. Guess what? It's getting to be a burden for normal people. Healthcare as a share of the average wage. Here I divide per capita healthcare spending divided by the average wage of Americans. 6% in 1970 when Canada adopted single payer. And they love. They're still mad about 1812. Yeah. So they call their plan Medicare, just to tease us. They come to us and say, "Oh, we have Medicare, just like yours, except better." So back in 1970, it was 6%. Now it's 20%. Guess what? Under the Affordable Care Act, it's going to be 24%. And I'll tell you something. This is not something the White House would deny. Yeah. The only person that I know associated with the Affordable Care Act who actually thinks it's going to control costs is Ezekiel Emanuel. And those of you who know him will vouch for me when I say that Zeke is insane. How much waste do we have? It's like we could have a fun game. This would be a good project for a graduate student. Coming up with all the different ways to estimate how much more are we spending than we should be spending if we were to be like everybody else. Okay, let's say we're like Canada. compared to Canada, if we spent only what Canada spends per capita, 48% of our spending is waste. Compare us to the other affluent countries in the OECD. Getting rid of the riffraff because they're different. So a comparison with them would make us look really bad. But we're not going to do that. Compare us with Germany, France, countries that are comparable. 52% because Canada actually spends a little more than the average for the OECD. So adjust this number for life expectancy in the United States, which is shorter. So here you're basically comparing us with Portugal. And 75% of what we're spending is waste. We should be able to reach Portuguese life expectancy at 25% the cost of what we're actually spending. Just say, okay, we're going to go back to 1971 and we're going to assume we acted just like everybody else. In that case, 44% of our spending is waste. How much is this money? How much is 50% of current U.S. healthcare spending? Anybody have any idea? You can shout it out if you don't want to raise your hands. In my classes, I have these mega lectures of 700 students Monday and Wednesday at 8 a.m. On the worst day of this past winter, when I walked the dog, and you can imagine, if a class at 8 a.m., I walked the dog pretty early, it was 23 below zero. It was much better. By the time I got to class, it was only 12 below zero. It felt like a heat wave. Anyway, I get to class with the dog at 8 a.m., and the students kind of come in looking as you'd expect, poor first-year students going to economics at 8 in the morning. Oh, my God. And I give a quiz every class. And if you don't take the quiz, well, I flip a coin. So, half after they filled out the quizzes, I flip a coin, and I only collect the quiz if I win. I pick a student. He or she gets to choose, and if I win, then the quiz counts, and they have to hand it in. But if the quiz counts and you didn't do it, you get a 0. So one time before the last class, I announced there would be no quiz in the last class. I thought everybody would still come because I'm so exciting. No, attendance was off by like 70%. There are so many empty seats. Anyway, so I do give people a chocolate if they answer a question or ask a question or if they just look particularly sad. I have students who come up to me and say, I'm having a really bad day. I give them a chocolate. Okay. Your first-year students need some nurturing. You can remember that. Okay, anyway, how much is healthcare spending in the United States? About $3 trillion. Half of it, $1.5 trillion per person. Divide that by 300 million, and you get $5,000 per person. That's about what this is. $5,000 per person. Wasted. Now, we're not doing, it would be one thing if we're spending a lot of money and we're getting a lot of nice things. There are a lot of things Americans spend money on more than other people. If we're doing that, then it's our choice, and okay. But no, we're spending all this money, and guess what? We're not even getting the health care. Here in visits per capita, here's the United States. We go to the doctor 4 times per person per year, on average. Some of you have gone more, some of you have gone less. A third of the people on Medicare did not see a doctor last year. They did not file a claim. Here's Japan. Unfortunately, again, we're losing the labels on some of these. Here's Japan. They go to the doctor once a month, more than once a month. Yeah. And they live a long time, remember? So you can't mock them. I mean, okay, you can mock them anyway, but after all, we did win that war. So okay, here's Spain. They go 7 times. In between partying and dancing and drinking sangria, the UK, they go 5 times. Canada, they go 7 times. You think Canada? It's like, come on. You cross the border from the United States to Canada, and it's like you don't notice. They watch the same TV as us. They should know better. They should have seen ER and what happens when you go to the doctor. But no, they go 7 times. We go 4 times. We just spend as if we were going 16 times. Where are our 12 doctor visits? Why don't we go? Because we're restricting access. This is what Zeckhauser and people recommended. Americans abuse the healthcare system because they have insurance. We need to reduce the insurance function so people will be paying on the margin for their visits to the access to the healthcare system. We need to restrict access, cost sharing, co-pays, deductibles, and it's working. We are making it hard for people to access the healthcare system. 37% of Americans report they had difficulty accessing the healthcare system. That is, they did not fill a prescription because of cost. They did not go to the doctor when they felt sick because of cost. They did not go to a follow-up, recommended follow-up, or specialist because of cost. This number is up substantially even since 2000. Notice, UK, 4%. Canada, 13%. United States, 37%. Those without insurance, 63%. That one nice thing about a number like this is it tells you there really is something meaningful here, because you would expect insurance should make a difference. It does. With insurance, it's 27%. So if we had everybody in the United States insuring these people, it would be a good thing. That's what the Affordable Care Act is about, increasing insurance coverage. And it is a good thing. You move people from 63% saying they cannot access the healthcare system because, of course, you move them to 27%. That would be really good. But 27% is still higher than any other country. Even if everybody in the United States was insured, given the nature of our insurance, the high co-pays, the high deductibles in our policies these days, we would still have a higher rate of the population saying they cannot access the healthcare system. About 2 years ago, my wife was cleaning out her pocketbook. Those guys here, and maybe women can understand what a scary thing this is to see. She poured it out, and she found all her old health insurance cards. Now, first of all, why do we have so many health insurance cards? We haven't changed our health insurance for 25 years. But she had a whole bunch. Because every year they send us one. Why do they waste all that money? There are 63,000 subscribers on the Group Insurance Commission's health insurance plans in Massachusetts. Every one of them, 63,000, over 100,000 people in the system. Every one of those subscribers and everyone else in their families gets a new card. All 63,000 get a thick booklet every year with a CD describing our options, because now we have like 30 options for insurance. Consumer choice. Now, my wife lined up her health insurance cards in chronological order, looked up at me and said, "Jerry, do you know what's happened to our copay?" Next time I wanted to go to the doctor, she looked at me and said, "Jerry, do you really think you need to? It's $35 now." Now I did. Actually, I don't even remember whether I did, but I did say to her, "Look, I earn enough money, we're well off. If I need to go to the doctor, I'm not going to pay attention to $35. Other people do have to pay attention to $35. Now, with all this, why don't I have to pay attention to $35? Because I'm over here, somewhere between the 81st and 95th percentile on the income distribution. So, life expectancy for people like me has gone up very substantially. In the richest 10%, where my brothers and sisters live, it's gone up 4.5 years. I'm happy for them. They're nice to me. They invite me to the house on Fire Island for a party every June. They look upon me as the poor younger brother who, if I need money or my kids need money, they let me know, they'll help out. It's all very nice. And I bring what we call nachas to the family, pride, because I'm the smart one. I'm the, I mean, they're all smart, but I'm smarter. Anyway, so where I am, we're not doing as well. This is increased life expectancy for Americans by income over the last 20 years. 4.5 years for the richest, 3.7 years for the next richest. The average for the OECD is 3.5 years. So everybody below the 80th percentile in the United States is doing worse than the average for the OECD. And it goes on and on. Again, it's unfortunate we're covering this thing because this last tenth, negative. The poorest 10% of Americans have shorter life expectancy than 20 years ago. It gets worse. Well, worse for some of you. Here's men. This line is life expectancy by income class 20 years ago. Here's life at age 55. Here's life expectancy by income class for men. Now, notice the line now is higher at all income levels. The gap has widened. Rich Americans are doing better relative to poor American men. But all American men are living longer. Here's women. It's gotten worse for the bottom 40%, for the poorer 40% of American women. Their life expectancy is shorter than it was 20 years ago, despite all the improvements in healthcare that have gone on. If you are feeling sad and angry, you're right. This is amazing. We're richer than we were 20 years ago. We have all these improvements in healthcare. We have all these other improvements. Cars, automobiles, even gun violence is down. You wouldn't necessarily be able to tell it, but, it is down. But 40% of American women are not living as long. Low life expectancy comes from restricting access to the healthcare system. Each dot here represents a county in the United States, over 3,000 counties. The horizontal axis is the proportion in the county reporting that they had difficulty accessing, that they had cost-related access problems. They did not go to the doctor because of cost. They did not fill a prescription because of cost. They did not do a follow-up because of cost. Notice, this line is upward sloping. Up here, you can see the R squared, 0.32, a very significant correlation for a cross-sectional regression like this. Here's the regression line. It actually is kind of pretty much a straight line. The more cost-related access problems you have, the higher the age-adjusted mortality. The more people die if they don't have access to the healthcare system. How many people die? If you believe this regression line, this number is so big I'm suspicious of it. But this is the one you get out of the regression. If you believe that, then if we had the UK rate of access problems, if only 4% of Americans had access-related problems, you'd move all the way down this line to over here, and we'd have 700,000 fewer deaths in the United States. A quarter of the deaths in the United States. We would move to the head of the queue. We'd be up there with, you translate that into life expectancy, and we would be up there with Japan. We're not with Japan. It's not that we don't eat enough sushi. I'm certainly trying my part to help with that. It's not that they get some benefit from Fukushima radiation or something. That hasn't gone on for long enough to show up in these statistics. It's that they get to go to the doctor. I mean, there are other things that go with this, like social safety net programs and all. So, as I work these things, I think that number will, the access thing alone will come down. But it certainly tells you this is a huge problem. How big is 700,000? What would you compare it to?
Portland, Oregon.
Portland, Oregon. Yep. We're killing Portland, Oregon every year. We're fighting a civil war every year. You know, a little more than 700,000 Americans were killed in the American Civil War every year. We're fighting 2 World War IIs every year. Every decade, we're killing New York City. You know, I don't know. Portland, Oregon every year, New York City every 10 years. You know, this hurts. You know, so. Okay, Americans believe our healthcare system's broken. We have the most unpopular healthcare system. You know, somebody yesterday was asking me, well, what do surveys tell you about single payer? Well, surveys tell you about 25% of Americans think our healthcare system's fine. You know, in contrast, the UK, over 60% think that's fine. You want to do a national regression? You line up these numbers, the proportion saying the healthcare system works well, and you compare it with the earlier numbers on the proportion with access-related problems. Very good correlation. Countries where people where people don't have cost-related access problems, those people like the healthcare system. Countries like the United States where people have access-related problems, they don't like the healthcare system. The United States is the least popular healthcare system in the world, for good reasons. Now, we've been doing all this. As I said, if we want to restrict access to save money, you know, maybe that's okay if we value the money. But it's not working. And it's not working because the things that have been driving healthcare costs in the United States are not related to our going to the doctor. You know, as I said, we already go to the doctor less than everybody else. What's been driving healthcare costs in the United States are rising prescription drug prices and the rising cost of administering the private healthcare system, private health insurance system, which not only is what goes on in the insurance companies, but it's what goes on in your doctor's offices, where we have more and more administration associated with the healthcare system because we have more and more people working in billing and other activities. The first time I saw this graph, I thought it was, oh, this is colleges. This is college administration. Oh, wait, we have an administrator here, so please. You're worthwhile. It's just at UMass. We have Einhorn's Law at UMass, named after one of my colleagues in poli-sci. Each university chancellor is worse. It's almost true. I've been there for 30 years. And we start out with an okay guy. Everybody's worse, except the current one. The current one is actually good. I don't know what happened. God smiled on UMass Amherst. It's wonderful. Anyway, here's physicians. Number of physicians has barely kept up with population. Here's administrators. Take my word for it. It's grown faster than population. Overall administration costs in the United States are $2,300 more than Canada. Remember, our healthcare costs are double Canada's? Well, there's a big chunk of it. Right there. Yeah. And raising co-pays, more cost sharing, doesn't reduce this. In fact, it increases it. Why do we have a more expensive healthcare system? The simplest reason is we've been using the market. And treating healthcare as a commodity is necessarily inefficient. If you remember back to the early 1970s, we didn't have single payer in the United States by any means. But we mostly had one private insurance company, Blue Cross Blue Shield. That's what everybody had. And they had community rating. Everybody paid the same rate. There were problems with that, but it was sort of a simple single-payer system. Then we introduced competition, more companies in the insurance industry. Now, how do you make a profit in the insurance industry? I mean, these companies that go into the insurance industry, and increasingly the Blues are all for profit now. Some of them have changed their names, to mark that they're for profit. How do you do it? How do you make a profit in the insurance industry? How do you make a profit in the Zappa industry? This Zappa is not as good as my Zappa.
You use it.
What?
You use it.
Well, how do you use it? You get people to buy your stuff. Yeah. You sell more. My father sold coffee. The Kensington Zappa company wants to sell more Zappas. The more they sell, the more profit they make. That's not the way it's done in insurance. The way you make profit in the insurance system is by identifying people who are going to use your coverage and getting them to go away. When they pay a doctor, when they pay a hospital bill, the insurance companies call that medical loss. And when they have a rise in their medical loss ratio, when they're paying your bills, you think that's good. Wall Street sits up, takes notice, and sells the stock. You see this. If you look in the Wall Street Journal, do a search on medical loss ratio, you'll see these articles. Medical loss ratio down for Cigna, stock rises. They're paying fewer bills, and the stock goes up. Medical loss ratio goes up, stock down. There's a rule, 70% rule. 70% of your costs as a health insurer, your medical losses, 70% go to 10% of your people. This is true for Medicare. It's true for most health insurers. How do you increase your profits? Find the 10% of the people who are going to get sick and get them to go away. We call that cherry picking and lemon dropping. Lemon dropping is when you find the people who are going to get sick, look at your neighbors, and you can tell, shorthand, who is going to get sick. It goes with white hair. It goes with taking prescription drugs every day. It goes with walking with a limp. It goes with sneezing a lot. It goes with having asthma. It goes with having depression and anxiety. It's not just old people. Young people can be risky, and they can be lemons that the companies want to drop. And cherry picking. Find the people who are going to be healthy and recruit them. Do things like offer them health club plans. What goes on in these offices in Hartford, Connecticut, and in New Jersey? Research to identify the characteristics of people who are going to be healthy and things they like, so they can offer those things. And the characteristics of people who are going to be sick and the things they don't like, so they can offer those things to drive them away. What is it that you over there like? I mean, you have glasses, which is a problem, but otherwise you look like the kind of person they want. Maybe cricket. Maybe a subscription.
10 pills a day.
You 10 pills a day. So we want to say that, okay, all we're asking of you is that.
Your conference is scheduled to end in 2 minutes.
Oh, is it really? Do we realize 2 minutes? No. Oh, okay, ignore that. Okay. Okay, next time we set up your plan. We say it's fine that you take 10 pills a day. All we ask is that every time you refill a prescription, you call the insurance company and get approval. Yeah. And then you hire only one person to answer all these calls. And the person doesn't speak good English and is in a different time zone. And you have to call at that time zone. Yeah. So, things like that. Profits are in sorting out the sick and healthy. Now, they won't necessarily say, oh, we don't want to give you insurance. What they do is they want to put you into a plan where they charge a higher rate. While they offer a lower rate to that gentleman. Monopolies are inherent here. Yeah, which is the second piece. What is the biggest monopoly in healthcare? Drug companies. They've legally sanctioned monopolies that they carefully protect their patents, and they carefully protect the patents by what's called evergreening. Research into redesigning the drugs so they can tweak the patent and keep it going for another 17 years. And then if you don't like it, well, you don't have to use the drug. You can die.
Your conference is now over. Goodbye.
Goodbye. Thank you. Thank you. Yeah. The other monopoly.